So welcome. Welcome to the ERA Journal Club. Each ERA e-seminar takes place on the last Thursday of the month at 1700 Central European time, which is 1600 Oxford time here in the UK. Each e-seminar picks out a topic, usually a recent original research article, but sometimes a key review article, and the author or authors introduce their work. There's at least one expert on our panel, and today it will be moderated by NDT Editor-in-Chief, Professor Denis Fouque, and myself. I'm Will Herrington. I'm an Oxford-based nephrologist and epidemiologist. Our discussion will last for up to 1 hour. It will be fairly informal, and we encourage live and hopefully lively questions from you, the listeners, typed into the Zoom Q&A box, and we'll try and address as many questions as we can. It will be recorded and made available on social media platforms, so keep an eye out for links later. Now, this is our second e-seminar since we've expanded to be the ERA Journal Club and both include NDT and CKJ articles. And I'm pleased to say today we've selected an NDT original research article to discuss. This will be the second time we've discussed NDT original research. And this is a question that I am regularly asked about in my renal practice, particularly from cardiology colleagues, where we share mutual patients and they want to start a Neprilysin inhibitor. And today, Clara Vollmer Barbosa, who is an MD from Hanover Centre of Internal Medicine to their Department of Nephrology and Hypertension, is presenting findings from her meta-analysis, a meta-analysis of 17 trials and over 20,000 participants. So welcome, Clara. And we're grateful to Bernhard Schmidt, who's a co-author and a colleague at Hanover, who's joined to support the seminar as an expert. And because Clara has brought a colleague member, I am maintaining the collegiate balance, and I've invited an Oxford colleague of mine to join the e-seminar. Dr. Parminder Judge is a senior clinical research fellow at the Renal Studies Group here at the Richard Dole Building in Oxford. Her doctoral thesis focused on Neprilysin inhibition, and she led and was a leading author on the UK HARP3 trial, which is one of the trials included in the meta-analysis. It tested a NEP inhibitor versus placebo on background of RAS inhibition in just over 400 patients with CKD. And I believe it's the largest of the NEP inhibitor trials in a dedicated CKD population and represents the lowest EGFRs in the meta-analysis. And so she will be able to contribute importantly to our understanding of this drug in the types of patients we see in our nephrology practice. She is also co-author of 3 articles in NDT about Neprilysin inhibition, and we will share some of the links to those subsidiary papers which may be of interest to you in the Zoom chat. So welcome, Bernhard and Parminder. So I'm really looking forward to today's presentation, but maybe I could start off, Clara, by asking you what got you interested in Neprilysin inhibition?
Hello, everybody. So I was working in outpatient nephrology a couple of months ago, and I saw a lot of patients with heart failure, but only a small fraction of them were prescribed SACUBITRIL, VALSARTAN, and I was just wondering why. So basically, this is how I got into it.
Great. Well, I think that's right. These drugs have shown clear effects in heart failure populations, but maybe not have been used as widely as one might expect from the spectacular results. So would you like to show us some of the findings from the trials that you've been pooling with your slides? And Clara, don't forget to unmute yourself.
Sorry, thank you again for the invitation to this journal club and for the opportunity to present the results of our meta-analysis in which we studied Neprilysin inhibitors and the effects on renal events. And thank you for the introduction, which allows me to dive right in. First, I would like to give you a quick overview about what to expect from me today. I'll first give you some background information about the drugs of interest, so about SACUBITRIL, VALSARTAN, and OMAPATRILAT. And then I'll tell you about one of the biggest trials on SACUBITRIL, VALSARTAN, which was the PARADIGM-HF trial. And then I'll tell you about the aim of our study, about the inclusion and exclusion criteria we defined, and the endpoints. And then I'll guide you through the selection process and give you some baseline information about the included studies. And then, probably most interesting for you, I'll present the findings of our study to you. And then I like to wrap it up and give you some points on what I hope you take home from this presentation. I don't have any conflicts of interest. And now let's start with the first drug of interest. SACUBITRIL, VALSARTAN is a drug that's taken orally, and after oral intake, it's divided up into its two active components, SACUBITRILAT and VALSARTAN. And SACUBITRILAT blocks neprilysin. And neprilysin is responsible for the breakdown of natriuretic peptides and bradykinin, among others, into inactive fragments. So by blocking neprilysin, those substances stay in circulation active for a longer period of time. VALSARTAN, on the other hand, blocks the AT1 receptor, and together this makes up the effects of the drug: an increase in vasodilatation, a decrease of the sympathetic tone, and an increase of the parasympathetic tone, natriuresis and diuresis. OMAPATRILAT, on the other hand, is a drug that this because it actually never gained market authorization. I will tell you in a minute why. We still decided to include it into our meta-analysis because it has a comparable mode of action as SACUBITRILAT, VALSARTAN has, and there were quite some big studies on it. So OMAPATRILAT blocks neprilysin just as SACUBITRILAT, VALSARTAN does, but in contrast to it, it blocks ACE. And again, you can expect the same effects: an increase of vasodilatation, a decrease of the sympathetic tone, an increase of parasympathetic tone, natriuresis and diuresis. But in the big trials, they saw a safety signal concerning angioedema. And this is probably because both enzymes block the breakdown of bradykinin. And this safety signal eventually led to the stop of the trials, and it prevented market authorization. The PARADIGM-HF trial is one of the biggest trials on SACUBITRILAT, VALSARTAN, with around 8,400 patients with class 2 to 4 heart failure with reduced ejection fraction being included in it. And those patients were divided up into two groups, one being treated with SACUBITRILAT, VALSARTAN, and the other one with enalapril. And the study was stopped early because it crossed the boundary for an overwhelming benefit of SACUBITRILAT, VALSARTAN after 27-month median follow-up time. Here you can see one of the primary endpoints of the study, a composite of death from cardiovascular causes or hospitalization for heart failure. And the black line represents enalapril and the red line represents SACUBITRILAT, VALSARTAN. And after 27 months, the primary endpoint was reached in 26.5% of the enalapril group, but only in 21.8% of the SACUBITRILAT, VALSARTAN group, which made a reduction of the absolute risk of 4.7 percentage points. They also defined the endpoint death from any cause. And again, after 27 months, the endpoint was reached in 19.8% of the enalapril group and 17% of the SACUBITRILAT, VALSARTAN group. This made, again, a reduction of the absolute risk of 2.8 percentage point and was statistically significant. They also defined other endpoints like death from cardiovascular causes and hospital admission due to heart failure, and again were able to show a benefit from SACUBITRILAT, VALSARTAN. These eventually led to the approval of the drug for heart failure with reduced ejection fraction by the FDA in July 2015, and shortly after by the European Medicines Agency in November 2015. And the drug also found its way into the guidelines. Here you can see a part of the guidelines of the American Heart Association, which recommend the use of an ARNI, so sacubitril valsartan, as a co-equal option to an ACE inhibitor or ARB in patients with heart failure with reduced ejection fraction. And they also recommend the replacement of the ACE inhibitor or ARB by an ARNI in case the patient stays symptomatic. And also the European guidelines recommend the use of the ARNI in the same way as the American guidelines do. So all in all, on the first glance, this does sound like a real success story, but I'll show you some data now which questions if the story of sacubitril valsartan really is a success story just yet. Here you can see the results of the CHAMP-HF registry. They explored how many patients with heart failure with reduced ejection fraction actually get treated by the recommended therapy. And what you can see here is that the numbers aren't too bad for ACE inhibitors and ARBs and for beta blockers, with at least more than half of the patients being treated. They are already pretty bad for the mineralocorticoid receptor antagonist, with only 33.1% being treated, but they are the worst for the ARNIs. What you can see here, and learning this really shocked me, that only 13% of the eligible patients are being treated. I can say now that this is a study from 2018, and this is some time ago. There's another study from Canada from 2020, and they found out that 225,000 patients in Canada should be treated or would be eligible for sacubitril valsartan, but only 27,000 actually get treated with it. So again, approximately 12%. And this is a real problem because we have a very potent drug that is not only known to decrease the symptomatic burden of the patients, but also showed in big trials that it can decrease the hard endpoints like mortality and hospitalization. And on the other hand, we have data that shows that it's not used. And of course, the question is why? If you look into literature why new drugs are not prescribed, there are a lot of reasons you can find. One reason, for example, is you are more likely to be prescribed with a new heart failure medicine if you go to a cardiologist instead to a general practitioner. Another reason is that doctors tend to stay with drugs they have a lot of experience with because they have safety and efficacy uncertainties. So we think that one of the reasons why sacubitril valsartan isn't used is safety concerns of prescribers. So as nephrologists, of course, we care about the kidney first. So we ask the questions, are neprilysin inhibitors in combination with an ACE inhibitor or ARB safe in terms of renal events? And in the big trials, you can find some data on this, but it's usually really hard to find and not the main focus of the study. And sometimes you even have to go to the supplementary data to find it. And so what we wanted to do is we wanted to compile all this data into one big meta-analysis to create powerful results for prescribers. And we are really happy that the NDT accepted our work for publication. I'll tell you about the inclusion criteria we define now. We decided to only include randomized controlled trials as they hold the highest level of evidence, and only articles in English or German language. And the intervention group was supposed to be treated with the combined neprilysin inhibition and an ACE inhibitor or ARB, and the control group with an ACE inhibitor or ARB. And of course, the study needed to provide information about renal adverse events or renal endpoints. We did not include observational studies, case series, case or animal studies, and no conference abstracts or posters. And also we did exclude studies with a duration of less than 8 weeks. As endpoints, we defined all renal events, and then acute renal events, and the subpoints here show you what is included into this endpoint. And then severe and non-severe acute kidney injuries in particular, and chronic renal events, the absolute change in EGFR, and hyperkalemia. I'll guide you through the selection process now, which we did according to PRISMA guidelines. And we searched PubMed, Cochrane, clinical trials, and Embase with our search term. By this, we found approximately 6,000 articles of interest. After exclusion of duplicates, we were left with 4,700. And then we screened those articles first by title, then by abstract, and lastly by full text. And this way we were left with 17 studies. Here you can see the studies we ultimately included into the analysis, and I will guide you through this table now. So the studies were published between 2000 and 2021. They were all randomized trials, and 2 studies used OMAPATRILAT as the study group, and the other one SACUBITRIL, VALSARTAN. And as control drug, 10 studies used an ACE inhibitor, and 7 studies used an ARB. Study size varied between approximately 100 and 8,400 patients, with a 700 patients being included. Mean age ranged between 52 and 73 years, and the majority of included patients were male. I will present to you now our findings. We did the statistical analysis with Review Manager and R, and in R we used the meta package. As first endpoint, we did all renal endpoints, so we included all renal events we could find into the analysis, and this way we were able to include 16 studies into the meta-analysis with a total of 23,500 patients. There were 2,767 events in the study group, which was treated with a Neprilysin inhibitor, and 3,295 patients, 3,295 events in the control group with the patients with the ACE inhibitor or an ARB. In the orange circle, you can see the odds ratio, which is with 0.81, pointing towards a benefit of the Neprilysin inhibitor. And right behind, you can see the 95% confidence interval, which isn't crossing 1, which means that the result is statistically significant. If you take out the first 2 trials, which are the ones by Rollo and Packer and other ones that used OMAPATRILAT as the study drug, both groups perform equally well. Next, we only included studies that reported severe acute kidney injuries, and there we found 6 studies that reported this event. And this gave us data of around 15,000 patients, and there were 183 severe acute kidney injuries reported in the study group and 207 in the control group. The odds ratio is 0.88, but in contrast to the last analysis, you can see that the 95% confidence interval is now crossing 1, which means that the result is not statistically significant, but that both groups perform equally. The studies use slightly different terms to describe acute renal events, and they also use slightly different definitions. And in the next trial, we included all of those acute events, giving us data of around 22,000 patients and 1,795 acute events in the study group and 2,151 events in the control group. Again, the odds ratio is pointing towards a benefit of the Neprilysin inhibitor. And here again, the result is statistically significant. And if you take out the study of PACA, which is the one using OMAPATRILAT, it stays significant as well. So there were less acute renal events in the study group compared with the control group. Of course, prescribers not only care about acute events, but also about the long-term outcomes of the prescribed drugs. And this is what we wanted to address with our next endpoint. And there we included all chronic renal endpoints that we could find. This gave us data of around 17,000 patients, and there were 445 chronic renal events in the study group and 486 in the control group. Again, here you can see that both groups perform equally. So chronic renal events had the same likelihood in both groups. The EGFR was only reported by 4 studies, but these were pretty big studies. So we got data of 14,000 patients, which is still more than half of our total group. And in the red box, you can see the mean decline of the EGFR in milliliter per minute per year. And in the blue box, you can different the control group again in milliliter per minute per year. And the meta-analysis shows that there's a mean difference of 0.6 milliliter per minute and per year. And this, of course, is a small difference, but it's a statistically significant difference. And it's a difference that might become relevant over time. For ACE inhibitors and ARBs, hyperkalemia is a well-known adverse event. And this is why we wanted to address this event too in our meta-analysis. And we were able to include data of 18,000 patients here. And there were 984 hyperkalemias in the study group and 1,110 in the control group. So again, there's no statistical significant difference between two groups, and hyperkalemias are just as likely in the study as in the control group. So now that I presented to you our results, I would like to give you some take-home messages. I hope I was able to show to you that there are less acute renal events when comparing treatment with sacubitril valsartan to ACE inhibitor or ARB therapy, even though the difference is small. And the information on progression of renal insufficiency is scarce, but the fear of a progress under sacubitril valsartan is unfounded, and there might even be a small benefit for sacubitril valsartan therapy. And there's no difference in rate of chronic kidney events or hyperkalemia. Let me remind you again that sacubitril valsartan is still widely underutilized in heart failure treatment. Like I showed to you before, only a small fraction of patients is actually being treated with this drug. And this, even though it is recommended in the guidelines, and we have big studies that show that that it's a very powerful drug in heart failure. And we hope that our findings help to disperse safety concerns of prescribers to ultimately promote a broader use of ARNIs so that the questionable success story eventually becomes one. So this is the end of my talk. Thank you for your attention.
Thank you, Clara. I really enjoyed seeing all of that data aggregated across nice forest plots. Before I ask the panel for their questions and thoughts, please do enter your Q&As for Clara and the team into the chat, and we'll try and address as many of them as possible. Clara, could I start with a question from you? Whenever you do tabular meta-analysis, it's frustrating sometimes when you want to extract data and can't find the data you want. Were there any pieces of data or analyses that you really wanted to do that weren't possible from the meta-analysis that would bring you to want to look at individual patient level data and do this in more detail? I have some suggestions for you in a minute if, as well.
Well, I was really disappointed that there was not more data on the EGFR. I mean, we did the analysis, but there were really little studies actually reporting about it. I would also have liked to do an analysis on patients with chronic kidney disease, but there are basically only the HARP trial addressing this theme, so that was not an option either. We could have done albuminuria, but there is already a meta-analysis addressing this theme, and I think there are not so many trials as well that address this theme, so this was pretty hard too. It's in general, for meta-analysis, what I learned now is that the data you produce can always be just, I mean, can only be as good as the baseline data you get, basically, and that's sometimes a little bit frustrating.
So, I was going to ask Parminder about the albuminuria and blood pressure results in a minute of the HARP3, but I just wanted to, your EGFR slope analyses, since all of these trials published, obviously the FDA and EMA will now accept EGFR slopes for submissions for drugs and to get approval for licenses for use in CKD. Your plot of EGFR slope differences, could you tell us a bit more about the slopes? How long were they over? Were they the chronic slope or the total slope? Are the slope analyses there? Because that seems to be an obvious place where collecting individual patient level data and running slope analyses using acceptable analysis methods would be potentially very informative.
So I hope that I really got your question there. I'll try. If I don't answer what you want to hear, you have to correct me there. All the studies we included there were at least 1 year long. This is why we got yearly data there. But most of them really just were a year long and not longer. There was just one study that was longer than 1 year in the 4 studies that we used for analysis of the EGFR.
So, but I think, Will, you are right, because if you have patient level data, so creatinine is measured as a safety measure in each patient at every visit to the study center. So if we have the patient level data of all these studies, and it's just one company who has the drug, so there should be the data should be on file somewhere. So you can really do slopes, might be short slopes for half a year, but it should be possible if you get the data.
Yeah, I think that would be really interesting if you wanted to take this further, Clara. So you mentioned albuminuria. I was wondering if I could bring Parminder into the discussions, because obviously she ran the CKD trial. There's a question about CKD stage 3, 4 in the Q&As, but I was going to ask, as we brought up albuminuria first, whether Parminder might tell us a bit about the effects of these drugs on blood pressure and albuminuria, and maybe acute effects on EGFR.
Yeah, so the data is very variable, with most of the data coming from the heart failure population. So in the heart failure population, actually, the results while we were doing the trial, the UK HARP3 trial, were of concern to us, because actually, although all the participants in the heart failure trials had normal levels of albuminuria, in fact, sort of very low levels of albuminuria in the normal range, sort of about between 3 and 5 milligrams per millimole at each visit, albuminuria at the time points when it was checked appeared to increase. So still within the normal range, sort of, for example, in the Paradigm heart failure trial, it increased to up to 9 milligrams. So it was about a 50% increase. So although the increase was still in the normal range, if that was a rise in albuminuria in a CKD population, or certainly in a proteinuria population, that would be of significant concern. reassuringly, in the UK HARP3 trial, which was a population of patients with CKD stage 3 and 4, with an EGFR between 20 and 60 mils per minute, we actually showed a trend towards falling levels of albuminuria, a fall of about 9% across the 12 months of the study, although it sort of just missed statistical significance. Our p-value was about 0.06. So that was very reassuring for us that we didn't show the same effect in people with proteinuric CKD of a wide range of etiologies. As you'd expect, these with SACUBITRIL VALSARTAN, these drugs are a very potent blood pressure lowering agent with blood pressure effects of about 6 and 4 or 6 and 2 millimeters of mercury seen in the heart failure trials. And in the HARP3 trial, we found a blood pressure reduction of 7.5 and 2 millimeters of mercury at sort of 3 months. By 12 months, the effect on blood pressure was no longer significant between the two treatment arms. Our comparator, active comparator, was irbesartan. So we didn't find a significant value of the difference at 12 months, but we did see a striking result on blood pressure.
Okay, so that's very useful, isn't it? So in clinical practice, if you start to use these drugs, you can expect large blood pressure changes. And you shouldn't be concerned by the heart failure results where albuminuria levels are increased. We don't expect that to be the case in a population of CKD. Bernhard.
Yeah, I would like to comment on albuminuria on EGFR in this setting. So Neprilysin inhibitors might a little bit increase glomerular pressure, so it might cause a little increase in albuminuria and increase in EGFR. So it's a hemodynamic effect we see when we look at our short studies. And I think it's very difficult to get some clue out of it for long-term effects. So I think it's really necessary to have a long-term trial focusing on kidney function if you want to get really to know whether it is a renal protecting drug or not. It's very difficult from the data we have now.
Yes. So, Bernhard, do you think there is something different about CKD in patients with heart failure compared to patients without heart failure? I mean, it's striking. The all renal event results suggest some benefit, but the trials that have generated that result are really only the heart failure trials. Do you think there might be something different between how kidney disease progresses in people with heart failure compared to maybe the more general CKD patients we see in our patient groups, like people with diabetes without heart failure?
Yeah, I guess so. So what you see here, if you improve heart failure. So if you improve heart failure, your cardiorenal syndrome gets better and renal function gets better. This is what you see in the heart failure patients. In the heart failure with reduced ejection fraction patients, might be even different in the HFpEF patients. And it's exceptionally different if a patient has a proteinuric kidney disease. This might be a completely different ballgame. So I would be, I don't know whether I would, the other thing you have to think about is high blood pressure. If you lower blood pressure sufficiently, this is the most important thing. So we will have a potent, this is in this discussion very much in the background. This is a really potent antihypertensive drug. So I have to admit, I have an outpatient clinic for treatment-resistant hypertension. I never used it before until I learned from Clara that it might be helpful.
It's very potent, isn't it? Denis, you had a point or a question.
Yes, the nice thing with meta-analysis is that sometimes you're able to dig out some hypotheses that were not addressed in the main papers. So I refer here to renal function protection. And apparently you found a very interesting observation that renal function improves under this treatment. Do you have any hypothesis for that? Is this just improvement in cardiac outflow or whatever? Do you have some hypothesis for that improvement?
Yes, this was what I suggest, that it is getting improvement in cardiorenal syndrome. This is I think this is the case here. I think it's overstating the data if you put more in it. Yeah. And lowering blood pressure should even make GFR lower. So it's I think it's really the improvement of heart failure, which is important here.
I guess it could go in both directions. I wondered if Parminder, you wrote her thesis and mulled about this mechanisms for a long time. So I wondered if you had anything you wanted to share about the acute effects on EGFR.
Yeah, I mean, certainly, clearly in people with heart failure, the sort of, I think that the kidney function is obviously more dependent on cardiac output in people with as compared to in people with CKD. In the way that these drugs work is that you get a relative vasodilatation of the afferent arteriole with a relative vasoconstriction of the efferent arteriole, despite a reduction in overall systemic blood pressure. And the point is to try and maintain GFR, and that's in the face of sort of widespread reduction in systemic blood pressure as well. Which is obviously more, it's more able, GFR is able to be more maintained in the heart failure population, but sort of but not so much of an issue in people with CKD who have got loss of nephrons over time because of hyperfiltration and loss of nephron function. But obviously that's not the same mechanism of impaired kidney function in the heart failure population. So there's a lot more compensation that's possible in those individuals.
So is this finally like a diuretic effect? And so we improve congestive heart failure, such as SGLT2 inhibitors.
Yeah, I think you're right. Dennis, one of the questions we have in the chat is actually is a question about experience on dose tolerance in patients with CKD 3B and 4. We saw reassuring data on acute kidney injury already from the meta-analysis. I assume from the fact these drugs have been marketed that we've resolved the issue with angioedema. So I don't know whether or not you noted any other safety concerns in your meta-analysis, Clara, and then I'll see what Parminder noticed in HARP3.
Yep. Yeah. So no major safety signals in a patient population, as I said earlier, with GFRs ranging between 20 mils per minute up to 60 mils per minute. We did not see any excess of angioedema, although, as I said earlier, our population was only 400 participants. However, we did notice on pharmacokinetic analysis that with every 10 mil reduction in GFR, that there was an increase in the level of SACUBITRILAT, which is the active component of the sacubitril valsartan. So sacubitril valsartan is a prodrug, the Neprilysin inhibitor, which is then, so the sacubitril is then broken down further to sacubitrilat. But we did not see, so we did see increasing levels of the active compound in the circulation of individuals that with CKD on this drug with falling GFR. But it didn't cause any major signal in terms of safety. However, numerically, we did see a numerical excess of non-significant postural hypotension, so which is in keeping with the expected effects. But obviously, if the drug is hanging around in the body for longer, you'd expect the blood pressure to have a slightly bigger effect.
Parminder, did you ever look at the effects on blood pressure by level of renal function? Did you have enough data to be able to look at whether or not people with more advanced CKD had larger blood pressure lowering effects?
No, so we didn't look at that specifically. We did look, as a surrogate, we looked at the effects by numbers of antihypertensives that people were taking, and we saw no difference in the effect between the two groups by the numbers of agents that individuals were taking. So this is an effect on blood pressure that is specific to sacubitrilat, and whether it's related to GFR or not, we didn't have the numbers to look at that specifically, but it probably is related, I would imagine, from the pharmacokinetic analysis anyway.
In your study, what was the dose reached in the patients with low GFR the same as with normal GFR or higher GFR?
Yeah, so we so at the time when we did our study, it was the drug was still called LCZ696 at a dose of 200 milligrams. So we went up to after everybody was randomized to 200 milligrams of sacubitril valsartan, or well, LCZ, and then at 2 weeks following, we had a forced titration if their potassium electrolytes were safe, and they went up to 400 milligrams. So we used the maximum dose of sacubitril valsartan, and we only reduced the dose to half in those individuals that could not tolerate it for potassium, GFR, or blood pressure, really. But all individuals in our study were on the maximum dose of sacubitril valsartan.
There's another nice question in the chat. Giannina, who has asked the second question, and obviously is interested in CKD and use in CKD patients, asked about experiences in terms of quality of life and about quality of life measures and shortness of breath. I know you measured NT-proBNP in HARP3. Did you also measure any of the cardiomyopathy questionnaires or New York Heart Classification? What were the effects on shortness of breath and quality of life?
So in UK HARP3, we didn't look at quality of life measures. We had a very small study population. This was a phase 2 study. Mainly, sort of main priority was safety and efficacy, really, predominantly safety in a CKD population, because the data just wasn't out there. As you very rightly say, Dr. Herrington, we did look at NT-proBNP and we saw an 18% reduction, and we also looked at troponin and saw a 16% reduction from baseline to 12 months in the values. However, the heart failure trials, particularly Paradigm Heart Failure, did look at this specifically with a Kansas cardiomyopathy quality of life study questionnaire, and they did find significant improvements in quality of life, and that's sort of been echoed in all the other heart failure trials as well, with an improvement of at least 1 point, if not more. So I think you know, equality of life, symptom burden does improve significantly, and I think it's a combination of factors, the natriuretic effect, the diuretic effect, and the animal studies do show that these drugs are associated with anti-proliferative and anti-hypertrophic effects as well. So cardiac remodeling probably does have a major effect on why these drugs are so good in heart failure, but also in terms of the symptom burden. But we just don't have the data in a CKD population.
It sounds like the NT-proBNP results are consistent with what you'd expect, at least in a CKD population. We don't have the hard clinical outcomes. Clara, whenever these very large trials publish, you often find a lot of subsidiary analyses, often subgroup analyses. Did you read any of the subgroup analyses of the Paradigm and Paragon trials? Did you find subgroup analysis papers focusing on chronic kidney disease? Have they explored effect modification by CKD stage? Oh, we've lost Clara. I think we've lost Clara. We lost her.
We lost her.
Yeah, it's fine. Bernhard, do you know of any papers? And I'll ask Parminder if she knows of it. I think she might do, from her nodding.
No, I don't remember. I don't think so, but Clara might know better.
Okay.
So while we're waiting for Clara to come back, I can tell you that the large heart failure trials and Paradigm and Paragon did do a subgroup analysis by GFR of the effect of sacubitril valsartan versus enalapril or valsartan, respectively. They looked at GFR below and above 60, and there was no significant difference or no significant heterogeneity in the treatment effect. So very good quality, large randomized studies showing that that there's no major difference in the effect of treatment in the CKD population. But obviously, the heart failure trials, as I've alluded to, the patients in them, the nature of their CKD is very different, and at baseline, most of these individuals have GFRs of around 65, 70 mils per minute. So not the same group of patients that we typically see in our CKD clinics, but yeah, and certainly from UK HARP3, we didn't see any major concerns by kidney function, although we couldn't qualify it further beyond sort of the CKD stage 3 and 4 because we just didn't have large enough numbers.
Okay. Clara, thanks. Going back, I think you lost your internet briefly. Parminder answered your question for you, but I've got another one. But you showed some nice slides about potassium and you didn't see any clear effect on potassium. Were you expecting that? What were you expecting from this drug class which induced a natriuresis? Were you expecting to see any potassium shifts, and are there any messages for us in terms of monitoring? I'm thinking particularly about when you start this drug, we are wedded to the idea of whenever we change dose of a RAS inhibitor or initiate RAS inhibitor, doing a check of EGFR and a potassium. If we are, as I think I'm increasingly being convinced that seeing that these drugs are safe and we might see them used in CKD populations to treat reduced ejection fraction heart failure. If we do start them in a CKD population, is there particular monitoring advice? And is there anything you can advise given what you've seen in the data?
Well, actually, I really believe in that data that we found here. So I think that there is an effect on potassium, but it's not bigger than the one with the usual RAS inhibition we do. That's what I think. So I would monitor it just like I would an ACE inhibitor or an ARB here. I think that what does the rise in potassium is the VALSARTAN that is in the drug, and I think that the Neprilysin inhibition doesn't do anything. Maybe it's even a little bit protective because it has this slight diuretic effect.
And Denis, what do you do in France? Do you, when you start these drugs, do you monitor EGFR, potassium when you use these drugs in practice? And do you do anything different in CKD?
In fact, that was another point. These drugs are not really prescribed by nephrologists first. They are referred to cardiologists. And the cardiologists call us, what should we do? Should we reduce dose, etc. And in my experience, I have some patients since for 5 years already, and we always succeeded to maintain the drug to the cost of reducing dose, in fact, and mainly because of blood pressure, not from metabolic abnormalities. No potassium problem, no increase in serum creatinine, but mainly because blood pressure fall too low, so we cut the dose. But I never stopped the drug in CKD for patients. So I think it's really something that should be added to the patients, and possibly with SGLT2. So that was my joker question, but what do you think about a potential add-on with SGLT2, too many diuretics? Any experience in that?
I haven't seen it. I've seen a lot of people looking at analyses of MRA in combination with SGLT2 inhibitors, and it doesn't seem to raise new safety concerns. I haven't seen any of the sort of similar analyses looking at the types of patients on a NEP inhibitor with an SGLT2 inhibitor.
But so far, there is no reason not to.
Not with careful monitoring of volume. It sounds like you could be very effectively lowering blood pressure, couldn't you? Yeah. So, are there any other NEP inhibitors being developed? You excluded short studies and small studies. Did you spot anything other than SACUBITRIL VALSARTAN? Is there another drug like this in the market where there might be an industry funder who is planning to do a large-scale trial, or are we going to be left with the data that you've shown and nothing more?
I didn't find anything. I don't know, maybe there has been something in the last few months, but until the time I searched those databases and we really looked at all those studies, and there was 6,000, I didn't see anything.
And in Congress abstracts, have you looked at cardiology congresses recently, maybe? Not yet.
No.
Well, I mean, we had some posters actually, because MBase found a lot of posters and abstracts from cardiology conferences, and there was nothing in it either.
Okay. Bernhard, did you have anything you wanted to add?
Yeah, so I have I'm thinking about why do we nephrologists do not use this drug more? So we are so much into SGL2 inhibitors, and we are waiting for the non-steroidal mineralocorticoid receptor antagonists, and we completely left this Neprilysin stuff to the cardiologists. I don't know why.
Again.
Yes, unfortunately, there was never the CKD trial. I know there were efforts to start a CKD trial, but it never took off. I know there is no plan for a large-scale CKD trial. It would seem that any large CKD trial could be run similar to the type of trial that you've seen with the non-steroidal mineralocorticoid receptor antagonist finerenone and with the SGLT2 inhibitors. We could run a trial looking at cardiovascular death and kidney disease progression as a primary composite outcome, because it would seem that this drug should benefit both, given you've got the data on heart failure and you've got the data.
I think it should be and it should be a trial with a baseline treatment of SGL2 inhibitors and then an ASO-ARB versus SACUBITRIL VALSARTAN. So we have kind of turn it around now. SGL2 inhibitors I think is the base for everything, and then we can figure around this renin, angiotensin, aldosterone system.
Yes,
which we have done for 20 years now.
I think we've missed a window of opportunity, because obviously before the SGLT2 inhibitors came along, there was high rates of renal progression. I think any trial now will be needed to be performed with people on an SGLT2 inhibitor as well as RAS blockade, and the event rates will be low, and so the trial will have to be increasingly large. So there's a missed opportunity in nephrology. Any final comments from you, Clara?
So one thing that I might want to point out again is that we did not see a difference in chronic renal events. And one reason why this might have been so is not only that the studies were too short, but also that chronic renal events were in the trials had like really hard definitions. It was like they needed at least like a minus 50% reduction in GFR, for example. So these were like really, really hard to reach, basically. And this might have been one reason why we didn't find anything there.
Okay, well, maybe you can persuade Novartis. You're going to submit for data sharing and plan a whole series of categorical kidney outcome and EGFR slope analyses using the individual patient data and aggregate pooled analyses. That sounds like a project, and it would be well worthwhile. I'm sure the renal community would be very interested. Denis, any last comments from you?
I think we heard very interesting information. I'm puzzled that this new drug is not spread enough in patients. Again, it's a normal problem. We need to wait 5 to 10 years after the clinical trials to implement in patients' care. So hopefully it will not be that long now. And I also question the add-on of this drug to other very efficient new drugs, such as mineralocorticoid inhibitors and SGLT2. So we have now an armamentarium that increases for our patients, and I think it's very nice. And just to close up, I think it's now almost 5 o'clock tea time for UK.
Yes, so yes,
we lost our tea. It's your time now. And,
so yes, so that's great. So I mean, I think next time the cardiologists call a nephrologist and ask about NEP inhibition, I hope this seminar will have given you the answers. I think it's safe. There won't be an excess of acute kidney injury. We would recommend some monitoring of EGFR and potassium, but we're not expecting hyperkalemia. But do be careful with doses. Increase the dose slowly, because these are very effective antihypertensive agents. And although we don't have evidence that they'll benefit the heart failure, there's no reason to feel that we don't think that the the use to reduce risk in people with heart failure is likely to be diminished by the presence of CKD. So yes, I think positive reinforcement of the use of this drug, trying to overcome the therapeutic inertia, and hopefully with prices coming down, the benefits can be realized by patients. So thank you, Clara, Bernhard, and Parminder, from myself and Denis, for your time today and the brilliant presentations and sharing all your knowledge. We really appreciate it. We've seen the worldwide randomized evidence on NEP inhibitors presented and discussed. Please do go to the NDT website and read Clara's meta-analysis, and we've sent you the links for other reviews. If you're a cardiologist, please think about using this in patients with CKD. They are high risk and an undertreated population. As always, please answer questions on the survey after this meeting. We really appreciate your feedback, and we need it to keep the e-seminars running. And if you enjoyed this e-seminar, then please put a new date in your diary, Thursday, the 28th of April, the last Thursday of the month. Please do join us again. Jennifer Lees and Kate Stevens will be presenting another meta-analysis, but this time the topic will move to induction and maintenance therapy for ANCA-positive vasculitis, which should make a lively discussion, and I hope equally interesting. But for now, it's goodbye from Denis and myself, and enjoy your tea.
Thank you very much, and bye-bye.
Bye.
Bye.
Bye.